A very good evening. On behalf of Neurocritical Care Society of India, I welcome you all for the Journal Club for today. Today we have with us Dr. Karthik, who is a second year DM resident at NIMHANS. He will be presenting on the DASH trial. Over to you, Dr. Karthik.
Good evening, everyone. First of all, I thank Neurocritical Care Society of India for providing me this opportunity to present this trial. So, the trial that I'm going to present to today the, um, is desmopressin for patients with spontaneous intracerebral hemorrhage taking antiplatelet drugs. That is a DASH trial. It's a UK-based phase 2 randomized placebo-controlled multicenter feasibility trial. So now, as we know, intracerebral hemorrhage, in year 2019, there were 3 million worldwide deaths due to spontaneous intracerebral hemorrhage. Over two-thirds of the survivors become dependents, and approximately 25% of these patients are on antiplatelet drug. As we know, this patient population proportion is increasing, especially in the developed and the high-income countries. Now, the pre-stroke antiplatelet drug is associated with 27% of relative increase in 1 month case fatality as when it is compared to no antithrombotic agents that are being used. So the risk of death from spontaneous intracerebral hemorrhage is increasing in patients with use of antiplatelet drugs. Now,
Hello, am I audible, ma'am? Hello.
Yeah, Dr. Karthik, you're audible. You can proceed.
So the hematoma expansion in intracerebral hemorrhage leads to poor prognosis, death, or higher disability rate. And in order to predict the hematoma expansion, some of the predictors are antiplatelet drug use, anticoagulants, the time of onset to baseline imaging, hematoma volume, and international recommendations lack a consensus in agreeing whether any correction agents for these antiplatelet medications can limit the hematoma expansion, thereby improving the prognosis. Now, only 3 retrospective trials cumulatively accounting for inclusion of around 263 patients have been done, that too retrospectively, in use of desmopressin in this scenario. So now desmopressin, as we know, it's already a pro-hemostatic, and it is used in inherited bleeding disorders. So the antiplatelet So antiplatelet drugs can cause increased bleeding and increase in the hematoma expansion, and the desmopressin can reduce bleeding for these patients. Now, coming to the related trials on this topic, the administration of procoagulant post procoagulant will help in reducing the re-expansion of hematoma. The fastest trial, which included administration of factor 7A up to 2 to 2.5 hours after onset of intracerebral hemorrhage, and the ongoing tranexamic acid trial have still not been fully completed, and the results are awaited. Now, coming to the rationale for the use of desmopressin, the platelet function remains inhibited almost up to 5 to 7 days after stoppage of antiplatelet drugs. This desmopressin, when administered in these individuals, can lead to increase of van Willebrand factor and factor 8 from the endothelial Weber Palade bodies. That increase in the van Willebrand factor will promote, number one, platelet adhesion to the collagen of the basement membrane, the interplatelet binding via glycoprotein 2B 3A receptors, and it has a potential to compensate for the platelet function defect that are associated with the antiplatelet drug. Also, the newer platelets that might be synthesized will be more procoagulant, which is also called as formation of procoagulant platelets. Coming to the guidelines, as we know, so the Neurocritical Care Society and the Society of Critical Care Medicine recommends a single dose of desmopressin, that is 0.4 microgram per kg, for patients who are undergoing a neurosurgical procedure for improving their platelet function. The desmopressin can be used in addition to platelet transfusion has been recommended. The American Heart Association and the Stroke Association advise that the further studies are necessary to determine if there is any benefit in intracerebral hemorrhage patients, that too in a subgroup of individuals receiving antiplatelet medications. The Royal College of Physicians and the Intercollegiate Stroke Working Party of the guidelines and the research British Society for Hematology does not provide any guidelines or consensus regarding this use of procoagulants. Now, coming to hypothesis of this trial, the authors hypothesized that desmopressin might reduce bleeding and improve outcomes in people with intracerebral hemorrhage. So, this was a phase 2 randomized placebo-controlled multicentral feasibility trial, and the ethical clearance was obtained by East Midlands Nottingham 2 Research Ethical Committee, and this was prospectively registered with IRCTN trial registry. Now, the trial was conducted between April 1 to 2009, April 1, 2019 to March 31, 2022. So the inclusion criteria for in this study were the adults who were aged more than 18 years, confirmed intracerebral hemorrhage on imaging, and those who were confirmed for imaging need to get randomized within 24 hours from the onset of symptoms or from when last seen free of stroke symptoms. So the amongst these randomized individuals, the necessary prerequisite was these patients were prescribed and they were presumed to be taking daily oral antiplatelet drug in preceding 7 days. So the antiplatelet drug could have been cyclooxygenase inhibitors, phosphodiesterase inhibitors, P2Y12 inhibitors. What were the exclusion criteria? All secondary causes of intracerebral hemorrhage like aneurysmal subarachnoid hemorrhage, hemorrhagic infarction, thrombolytic drug, venous thrombosis, AV malformations, or tumors. Now, the patients who were at the risk of fluid retention, systolic blood pressure when it was less than 90 millimeters of mercury, drug-eluting stent in previous 3 months, allergy to desmopressin, pregnant and lactating mothers, patients who were deemed not to survive for more than 4 hours or who were already receiving a palliative care, the patients with Glasgow Coma scale of less than 5 and modified Rankin scale more than 4. Now, coming to the enrollment process, if the patient was capable and conscious, the consent was obtained from them. In absence of a conscious patient, relative or friend provided the consent. If both was not possible, then professional who was not associated with the trial provided the consent, and once the patient improved, again consent was reaffirmed and retaken. Now, coming to randomization, so the investigators used the web-based computer a real-time random table generator which had a 5% random flip, and the randomization was programmed in order to match for age, gender, time of onset, since then systolic blood pressure and intraventricular hemorrhage. So the masking was done, and each individual once allocated and included in the study matched to the serial number which matched to the treatment pack. So identical 50 ml syringes which were stored between 2 to 8 degrees Celsius included of either desmopressin 20 microgram in 50 ml or a placebo that was normal saline in 50 ml syringe was provided. So the other than the person who prepared this medication, who did not know the individual getting allocated, the clinicians, patients, and the outcome assessors, that were clinical assessors, radiological assessors, and hematological assessors, were blinded from the group that was allocated. Once the data collection process, every recruitment center, roughly around 10 stroke care centers along the national NHS of UK participated in this trial. They provided a screening log which it included of age, gender, medical history, antiplatelet medications that prescription was available, the location of intracerebral hemorrhage, presence or absence of intraventricular hemorrhage, and modified Rankin scale. Again, once this recruitment and administration of intervention was done, these individuals were reviewed on day 2, on the day of discharge, and on 90th day after the intervention, for what was the interventions that they received, whether there were any adverse effects from the time of enrollment till 90th day, whether what was the discharge day, what was the discharge destination, whether it was home or nursing care. So, 90 days later, a telephonic interview carried out by a central assessor who were trained in delivering the appropriate questionnaires, who were masked to the treatment allocation, collected information regarding Barthel's index that measured disability on a scale of 0 to 100, with 0 indicating severe disability and 100 indicating no disability. Modified ranking scale to measure functional independence, ranging from 0 to 5 and 6 indicating death, with 0 indicating no disability. European quality of life, health state utility and visual analog scale for measuring quality of life, and for the cognitive status, telephonic interview scale, and Zunk depression scale for assessment of the mood. Coming to the radiological assessment, a central trained radiologist assessor who was blinded with the allocation used semi-automated segmentation to assess the area and the volume of intracerebral hemorrhage. For the definition of hematoma expansion was taken as absolute increase in the hematoma volume greater than 6 mils or a relative increase of more than 33% from the baseline. Coming to the laboratory assessments, the baseline platelet function consisted of stimulation of the platelet by arachidonic acid or ADP and measurement of the surface P selectin using an assay. And second one was von Willebrand factor and chromogenic factor 8 levels that was carried out at baseline and 1 hour after receiving desmopressin and placebo. So the serum sodium was assessed of 24 hours after intervention, and less than 135 was taken as hyponatremia, and less than 125 was taken as moderate to severe hyponatremia. What was the primary outcome? This was mainly a feasibility study, and they wanted to know the proportion of the patients who were screened, who were eligible, the amongst those screened individuals, who the number of patients who were enrolled, who underwent randomization, and reasons if they were not randomized, time to randomization after admission, and receiving their allocated treatment, adherence to the allocated treatment, the rate of participant recruitment per month per site, the proportion of the participants who were followed up to 90 days, and reasons if any if they were lost to follow up, proportion of the randomized participants with full outcome data available, and if any data was missing, reason for such. So what were the secondary outcomes? The change in hematoma volume at 24 hours, including the changes meeting the definition of hematoma, that was a 33% increase from the baseline. Hyponatremia at 24 hours, length of hospital stay, discharge destination, death and dependency at 90 days, which was assessed by modified ranking scale more than 4, mortality within 28 days up to 90 days, serious adverse events up from the start of the intervention till 90th day, disability at 90 days using Barthel's index, quality of life using Eurocall, cognition using the Zunk scale, and cognition using the cognition assessment scale, and mood using the Zunk depression scale, baseline platelet functions, von Willebrand and factor 8 levels, serum sodium, and all the side effects within 24 hours, and for less than from 24 hours till 7 days, according to their side effects and life expectedness, and any other fatal side effects that happened up to 90 days, for example, fluid overload or hyponatremia. Coming to the statistical analysis, the investigators did not calculate any formal sample size because this was a feasibility trial and they wanted to know what was the potential recruitment rate for a definitive trial. So assumption was that if more than 50 patients were enrolled from 10 centers in a 12-month period with the similar rates, approximately around 1200 participants in around 50 centers in a 5-year duration would be deemed feasible. So monthly screening logs and data were filled by the including enrolling center, and the data was assessed using SAS 9.4 software. A statistical analysis plan was decided by the team of investigators before freezing the database and then revealing the randomization. The independent data monitoring committee and chairman reviewed the data. The counts were expressed in terms of percentage or absolute number. The continuous data was expressed in terms of mean with standard deviation or median with interquartile range. The primary in the completed trial, the modified ranking scale at 90-day would be unadjusted, would be expressed in terms of unadjusted ordinal logistic or unadjusted binary logistic regression with 95% confidence interval. Now coming to the results of this study. So around 1,380 potential participants were screened, amongst which 1,204 were not eligible because they did not meet the inclusion criteria. So why did they not meet the inclusion criteria? Roughly around 843 individuals did not have any history of intake of antiplatelet medications. More than 100 around 152 patients presented from a time gap of more than 24 hours after the onset of symptoms. And in amongst the 152 remaining individuals, roughly 176 were 122 patients were eligible, but they were not recruited. Only 57 patients were an approach for consent, and 54 provided the consent. So amongst these 152 patients, why only 54 were included was: number one was odd hours of presentation to the hospital, absence of any active investigators who could enroll them into the study process. So amongst the 54 individuals who were randomized and allocated to the treatment, 27 allocated individuals received desmopressin and 27 received the placebo. Only 5 patients died in the intervention group, that is desmopressin, and 7 individuals expired in placebo group. So all the 27 patients were included in with the intention to treat analysis. Now coming to the participant characteristics. So as we know, there are no detailed statistical tests that are applied. They have expressed the absolute numbers in terms of percentage, mean, standard deviation, and median with the interquartile range. So the amongst 76 individuals, so amongst 54 individuals, roughly the age of presentation is similar among the desmopressin and the placebo group. So that is around 76.4 with a standard deviation of 10.7 in desmopressin, whereas 72.7 in a placebo group with standard deviation of 11.7 years. The gender distribution, as we know, has a slight difference, where only 59% of individuals who were admitted in the desmopressin groups were males, whereas placebo group had more proportion of males, that is around 74%. As it was conducted in UK, majority of the ethnicity was belonging to the white race, and we had one individual coming from Asian race in respective groups. Only one black individual was present in the desmopressin group. Now most important is the time from the onset to the randomization. So roughly the desmopressin group took around 10.2 hours with an range from 5 to 16.1 hours, whereas placebo group took 9.5 hours for randomization with range extending from 4.3 to 17.6. More than 3 hours, roughly around 85% of the patients were present in the desmopressin group, and 78% of the individuals were included after 3 hours of onset. More than 12 hours after the protocol, initially the protocol was designed to be kept up to 12 hours, but later on it was increased to 24 hours in order to increase the recruitment. So around 10 individuals were included in the desmopressin after the extension of this time interval, whereas 11 individuals, that is around 55%, were included in the placebo group. So from randomization till the treatment, the time duration was around, median time was around 0.6 hours in desmopressin and 0.8 hours in the placebo group. The other parameters such as modified Rankin scale, systolic blood pressure, diastolic blood pressure, history of ischemic or TIAs, history of ischemic heart disease, hypotension, hypertension, diabetes mellitus, atrial fibrillation, history of hemorrhagic stroke, peripheral arterial disease, hyperlipidemia are as mentioned. Now, coming to the participant characteristics which were related to the medicines. So, as we know, so around 25 percentage, around 48 percentage of the patients who were included in the desmopressin group had prescription of aspirin alone, whereas 44 percentage of the individuals in placebo group had intake of aspirin. Clopidogrel was present in higher proportion in the desmopressin group, that is 52 percentage, whereas only 33 percentage of individuals in placebo group had history of clopidogrel intake. The major drawback of this study, that is the dual antiplatelet therapy with combination of aspirin and dipyridamole and aspirin and clopidogrel, all 6 individuals were included in the placebo group. The NIH stroke severity scale for every entire population was roughly around 7, and for desmopressin group a higher stroke severity score scale of 7.5 was present, whereas for the placebo group a score of 7.0 was present. So the baseline CT scan was carried out roughly at around 2.8 hours in the desmopressin group, whereas it was little bit earlier, that is roughly around 1.9 hours for the placebo group. And from the time of scan to randomization, the timing duration was almost similar, that is 3.3 hours for the desmopressin group, whereas 3.4 hours for the placebo group. The location of the stroke, that is whether it was lobar, it was deep intracerebral hemorrhage or infratemporal cerebral hemorrhage, was similar amongst both groups, and whereas the was similar amongst both groups, but infratentorial ICH was included more in placebo group. Coming to intraventricular hemorrhage, so roughly the hematoma volume was roughly around 8.9 for overall all participants, of which 13.3, that is higher volume, was present in the desmopressin group, and 8.1 ml, that was a lesser volume, was present in the placebo group. More than 60 ml hematoma volume was seen in 3 individuals, that is 12 percentage in desmopressin and placebo groups simultaneously. Now, coming to the secondary outcomes that were measured at 24 hours and at discharge. So first at 24 hours, so sodium concentration was measured, and it was 136 in the baseline for all individuals, whereas for desmopressins and placebo it was 135.6 and 138.1 respectively. So the number of hyponatremia, that is less than 135, was around 8, that is 35 percentage for desmopressin group, and it was 3, roughly around 13 percentage in the placebo group. Moderate to severe hyponatremia was not seen in any individuals who were enrolled in the study. So the length of hospital stay roughly was 8 days for all entire study. It was longer in desmopressin group, that is 9, as compared to 6 of placebo group. The outcomes which were measured at discharge, that is the length of the discharge destination, home and independently discharged individuals were more in desmopressin group as compared to the placebo group, and the individuals who were discharged to the home with requirement of a care was more in the placebo group. The individuals who were discharged to the hospital who required rehabilitation were almost similar, with 3 individuals of desmopressin group as compared to 2 individuals of placebo group amongst 20 individuals. The 2 patients of placebo group required readmission, and only 1 patient of desmopressin group was present in hospital at the end of 1 day and was not discharged. Coming to the outcomes which were measured at 90th days, so modified ranking scale was assessed. So what we can observe in this modified ranking scale is the 0 to 4, which the number 0 to 4 is higher, this will be covered in detail in the subsequent slide, is higher in the desmopressin group, whereas the modified ranking scale of 5 to 6, which includes of higher disability and mortality, is higher in the placebo group. Coming to the other secondary outcomes that were assessed, had a uh, similar presentation, that is Barthel's index ranged between 71.6 in the desmopressin group as compared to 67.4 in placebo group. The other scores are mentioned in this slide as below. Now, the most important, that is the serious adverse effect that were studied, mainly were thromboembolic complication, and one individual in the respective group had incidence of thromboembolic complications. So the other complications like change in the hematoma volume, so it was zero point 0.1 ml for the overall entire participants. There was no expansion in hematoma volume as assessed in the desmopressin group as compared to expansion of 0.5 ml in the placebo group. The hematoma expansion was noted in 5, that is 21 percentage of desmopressin group as compared to 5 individuals, that is 23 percentage in the placebo group. Now coming to the modified ranking scale, which shows shift at the 90th day follow-up, what we can observe clearly is the higher scores were lesser in the desmopressin group, as we can observe that the modified ranking scale of 5 and 6 are higher in the placebo group as compared to the score of 2, 3, and 4, which are higher in the desmopressin group in the upper graph. Coming to the laboratory values for hematological assessments, so the baseline von Willebrand factor levels were assessed. So it was roughly around 2.2 mean for overall all participants. In desmopressin group, if baseline was 2.7, there was a change that was noted by zero point 0.1 zero point 0.1 international unit per ml, whereas in placebo group there was no change that was seen. In von Willebrand factor activity, the baseline von Willebrand factor activity was roughly around 3, and it increased by zero point 0.2 activity per international unit per ml, whereas in placebo group it increased only by zero point 0.1 international unit per ml. So in the assessment of chromogenic factor 8, so the desmopressin group had a change of zero point 0.3 international unit per ml as compared to placebo group, which had 0.1 international unit per ml. Coming to the side effects that were observed, so the serious side effects that were seen, majority of the side effects, cardiovascular events, that so majority of the cardiovascular side effects that included of heart failure or pulmonary edema was seen in 3 individuals of desmopressins, that was 11 percentage, as compared to 2 individuals of placebo group, that is roughly around 7 percentage. Amongst the other complications such as the hypervolemia and fluid overload, these were present mainly in the placebo group, and none of the and only hypotension and myocardial infarction were noted in the desmopressin group. The nervous system complications consisted of mainly expansion of the hemorrhagic stroke, and this expansion was higher in the placebo group in absolute number, that is 4 as compared to 6, and the complication of initial stroke was higher in a placebo group. Coming to the ischemic stroke that super added on the ICH, one individual was seen only in the placebo group. So there was more seizures in placebo group, that is 3 as compared to 2 individuals in the desmopressin. More individuals of desmopressin had weakness, that is 1 individual. And coming to the respiratory system, the majority of the individuals who had developed pneumonia belonged to the placebo group. Coming to the gastrointestinal side effects, diarrhea and other GI side effects were seen only in the placebo group. So hyponatremia was at 90 day was higher in terms of placebo group as compared to the anticipated desmopressin group. Coming to the discussion, this was a feasibility trial of running a large scale randomized trial, and of which around 176, that is 13 percentage of the 1380 eligible patients were tried to include in this study. Of this, only 52, that is 31 percentage, were recruited, and the follow-up system was effective to collect the data. There were no safety concerns, for example, thrombosis or any other major side effects that were reported. So, mild hyponatremia, although incidence was higher in desmopressin, there was no moderate or severe hyponatremia in the study. Conclusion: it should be the study concludes that it should be feasible to conduct a definitive trial based on the findings of feasibility trial, given sufficient recruitment center and pragmatic trial methodology. It might be more efficient if it is included as a part of a other existing trial or as a part of a platform trial. This feasibility itself could be delivered as a standalone study, and the increased frequency of antiplatelet drugs with a higher mortality and morbidity, even a smaller reduction in the morbidity or mortality, will lead to welcoming results in terms of reduction in mortality. So thousands of patients will be benefited from free of disability. Coming to the strengths of this study, it has successfully created a randomized data, which is very difficult. This study has a rigorous methodology and has been proven feasible. Although there is a lack of clear guidelines and consensus on intracerebral hemorrhage with a huge mortality burden, so as compared to the fastest 7A and TICH trial up to 24 hours from the onset, the greatest risk of hematoma expansion is seen in the higher early hours, and the antiplatelet therapy receiving up to 24 hours, we can expect some benefit by administration of desmopressin. So only the research active stroke units who were specialized in treating the stroke were participating in this trial. So that is a major limitation. Once more centers with a different recruitment rates become a part of this study, so there might be decrease in the enrollment rate, or the rigorous data collection process might be hampered. The recruitment was put on hold because of COVID-19 pandemic, and once this study was resumed, the rates never reached the pre-pandemic levels. The prolonged recruitment period meant the investigators sought funding extension, and this can have implications that can surpass the recruitment target, and it can fail to answer the original objectives. The other limitations, such as the screening log details were filled by the recruitment center, and the central team did not have any verification process to proofread the screening data. Placebo was not identical to desmopressin, as the person who prepared the medication had to load the drug from either ampule or from the normal saline unit, and hence one individual was aware of the medication. The major reason for exclusion was more than 24 hours after the onset of symptoms, and hence if the majority and major chunk of the individuals who present to the stroke with more than 24 hours after the onset of presentation might be missed including in this study. So this result might not be representative of a target population. The streamlining of the process from radiological diagnosis to drug administration in full-scale trial is required. So the all 6 individuals who received a dual antiplatelet therapy were placed in placebo group, and so the minimization of the prognostic factors, such as the baseline severity stroke and the antiplatelet therapy itself, can have independent confounding effect on the prognosis of intracerebral hemorrhage. Now, coming to some of the related studies of desmopressin. So first is the use of desmopressin in CABG emergency patients who receive dual antiplatelet therapy. So the desmopressin did not have any significant effect on bleeding control, and even delayed the hemostatic efficacy of tranexamic acid. So the use of tranexamic acid alone in this patient had a positive effect on hemostasis related data. Coming to the effect of local desmopressin on intraoperative blood loss and quality of surgical field during the functional endoscopic sinus surgery with a chronic rhinosinusitis, a triple-blinded trial. So this European trial showed that the blood loss was significantly lesser in desmopressin group as compared to the control group, and surgeons were more satisfied with the surgical field. The desmopressin can reduce blood loss in patients with massive hemorrhage who are undergoing other surgeries like gastrointestinal study. So this was a study conducted by Wang LC et al. Published in Turkish Journal. So the decrease in hemoglobin was significantly lower, and the sonoclot, that is thromboelastography, showed that the platelet function in the desmopressin group was better, that is higher in as compared to the placebo group. Now, coming to desmopressin as a transfusion sparing option to reverse platelet dysfunction in patients with severe traumatic brain injury. So, both desmopressin and transfusion of platelet had similar correction of platelet ADP inhibition that is seen in massive hemorrhage and transfusion related complication. Coming to the studies, related studies which are seen in management of intracerebral hemorrhage. So the dual antiplatelet treatment up to 72 hours after ischemic stroke, which was conducted by Young et al. And published in New England Journal. So the mild ischemic stroke or high TIA presumed atherosclerotic cause individuals, when they receive dual antiplatelet therapy, the risk reduction is seen at 90 days when they receive aspirin alone. And the dual antiplatelet therapy was associated with a low but higher risk of moderate to severe bleeding complications. The platelet transfusion versus standard care after acute stroke due to spontaneous intracerebral hemorrhage associated with the antiplatelet therapy. The patch trial, which was published in Lancet of 2016, showed advised that platelet transfusion, when administered 5 units if the patient received COX inhibitors or 10 units if patient received ADP receptors. So the platelet transfusion was found to be inferior to the standard care. The platelet transfusion was associated with the increased probability of death or disability or severe adverse events. So similar outcomes between vitamin K and non-vitamin K antagonist oral anticoagulant associated intracerebral hemorrhage was seen in study conducted by Chen et al. Now, coming to the last part, what are the implications of this study? So, in future, based on this study, we might have a baseline point of care testing of antiplatelet and anticoagulation levels in the stroke individuals. And once we identify the target beneficial group in whom individualized administration to desmopressin to improvise platelet function can become a norm. So the similar interventions are also being studied, and they might come up in other pathologies such as subarachnoid hemorrhage or traumatic brain injury in future. The iatrogenic or intracerebral hemorrhage in hospitalized patients during treatment, the desmopressin can be used to limit the hematoma and expansion related damage, and the prophylactic use in pre-surgical instance in order to control the local bleeding might be seen in increasing levels in the future. So I thank you and conclude.
Yeah, thank you, Dr. Karthik, for that wonderful presentation. Very elaborate and very lucid. So, like, it's very clear from the title that it's a phase 2 feasibility trial. So, based on this, it's not a treatment recommendation, but so what are your take homes based on the methodology as a resident, in this trial?
Mm, Number one is that we did not have a very detailed and complicated statistical analysis to prove that any medication can be beneficial, and they have more focused more on the methodology, and the protocol is very clear whether they are including. The methodology is very clear in terms of when they are assessing all the data has been collected in a very elaborate and a precise manner. The individuals who are recruited are followed up almost till 90 day with minimal loss of data, which gives a complete picture of treatment and its impact. So we can consider that study need not be very complicated in terms of statistical, and a simple intervention can be studied in a detailed manner. The blinding was very effective. Other than the person pharmacist who prepared the package in the seal envelope cover, none of the other individuals were exposed to the randomization of the group that was received. And if we go through the details, they have even gone to the extent of describing the number of medicine packets that were discarded, what were the excursions in the cold temperature chain that was happened during this entire enrollment trials. So this is regarding the methodology. So coming to the drug and its impact, we can clearly see that there is some amount of benefit in terms of reduction in the MRS and in terms of the hematological assessment that they have carried out. I would like to point out that the P-selectin assays, which they depended on the assessment of platelet baseline and the subsequent assessment, the company which manufactured this reagent, I think, had a shutdown, and still they were able to procure a very detailed data on what was the effect on platelet function. So we
Okay.
can consider desmopressin once the full-scale results have been published. We can try to enroll these individuals in our practice.
So most of there has been a lot of the AHA, the first guidelines which came out in 2014 with regard to desmopressin. That study actually had only 15 patients in the recruitment. Okay, so desmopressin has been gone in and out mainly because the study trial designs have focused on different outcomes. Starting
Yes.
from hematoma expansion to long-term outcomes, and as we all know, in the neuro-intensive care unit, there are lot many factors which affect the outcome, just not the ICH alone. Okay, so
Yes.
what are the prognostic factors you would consider for intracerebral hemorrhage?
So first is the duration of the stroke, the location of the stroke, what was the initial size of the intracerebral hemorrhage. So these become one of the most important prognostic factors. Though there are some of the non-modifiable risk factors such as age, gender, ethnicity, and amongst the modifiable risk factors, the hypertension is
Exactly.
seem to be a major factor. So achieving blood pressure reduction has already been clearly pointed out by AHA ASA guidelines is also very important. So not only control inside the hospital, the decrease the variability in the blood pressure, that is much more important in improving the prognosis. So these
Exactly.
are the other.
So yeah. Just one more question. So, compared to platelet transfusion, so the hypothesis is the hematoma expansion will reduce because desmopressin improves platelet activity. So, the one more question is on the chat. So, compared to platelet transfusion versus desmopressin, what are the advantages and disadvantage of both?
Number one is platelet transfusion itself comes with numerous side effects. It can increase the risk of infection. It can lead to complications such as TRALI and other immunological reactions. So that is one significant drawback in platelet transfusion. Second thing is this similar trial has been carried out in a different setting, that is in a traumatic brain injury individuals. There they have found that it is counterproductive. Better than transfusion of the platelets, it's better to not to transfuse, and other procoagulant molecules such as tranexamic acid or other desmopressin, I don't think so it has been studied in a much more elaborate manner in TBI group. So in ICH patients, we do not have as of now very as of my knowledge any study that clearly points out that this is better. But clearly we have a advantage because desmopressin is easily available and we are much more accustomed to use in neurocenter ICUs.
one more thing regarding desmopressin we need to be very aware of is the side effect profile of causing hyponatremia, because one side we are trying to manage ICP, so it does have that risk, especially when patient's ICP is high and you're trying to manage the cerebral edema. So the ICP tire therapy also has to be kept in mind. And one thing which they did a protocol variation in this study because of slow recruitment. So initial protocol was actually 12 hours of presentation, which they extended to 24 hours because COVID came in the way. And most of the studies before this have shown hematoma expansion to be maximum in the first 24 hours. So
Yes,
that is one of the factors which need to be considered in future trials, where early recruitment and then look for hematoma expansion in the first 24 hours to show whether desmopressin is the magic bullet in ICH. So, with this concluding remark, Dr. Karthik, I thank you once again for coming on and presenting a very lucid presentation on ICH and on the DASH trial on behalf of Neurocritical Care Society of India and Classroom Series. We wish to welcome you on in many more forums. Thank you very much.
thank you very much. I thank my moderator, that is Matangi ma'am, for providing this opportunity. And I sincerely thank all the NCSI members for, and if any errors or any mistakes, I'll try to improvise in the future. And I hope to see more in the coming days.
Yeah, thank you, Karthik. It was a wonderful presentation.
Thank you, ma'am.